Hi everyone, I just wanted to take this time to review the end of this lecture that we missed in class today. Week 9, Emergency Nursing 2, Fluid and Electrolytes, Endocrine System, and an Intro to Metabolic Disorders. For the final half of today's class, we will review the endocrine system. So we're just going to skip over the first few slides here, and I'm going to work my way down to the endocrine system. So the endocrine system is an integrated, complex system of hormone-secreting glands. The system is important in regulating metabolism, tissue function, growth and development, mood and emotions, and works to maintain homeostasis during stress. Dysfunction of one endocrine gland can often affect the physiology of the entire body. So without prompt assessment, identification, and management, endocrine disturbances may result in life-threatening consequences. Most emergencies we see in the clinical setting are related to diabetes. So the physiology of the endocrine system. The endocrine glands include the pituitary, thyroid, parathyroid, adrenal, and pineal glands. If you refer back to the handout from today's class, where you had to fill in the blanks for the major endocrine glands and their hormones, you will see which gland produces which hormone and the function of those hormones. We will also review some of these in class today. In addition, several organs and tissues that aren't classified exclusively as endocrine glands also have cells that secrete hormones. These would include our hypothalamus, our thymus, our pancreas, ovaries, testes, kidneys, stomach, liver, small intestine, skin, heart, adipose tissue, and placenta. Hormone activity is a result of feedback loops, nerve stimulation, and intrinsic rhythms. Renal and liver function and external factors such as pain, stress, or fear can also affect hormone release. Excessive amounts of circulating hormones inhibit hormone release, whereas low levels lead to increased release, really just trying to balance everything out and creating that state of homeostasis. Neural stimulation triggers increased glandular activity and release of hormones, and released directly into the bloodstream hormones are, and also to the target gland or organ to produce a desired response. But how do they do it? Hormones travel throughout the body in the blood, yet only affect the specific target cells, so they go where they need to go. Hormones influence their target cells by chemically binding to specific protein or glycoprotein receptors. Only the target cells for the given hormone have receptors that bind and recognize that specific hormone. So for example, thyroid-stimulating hormone, also known as TSH, binds to receptors on the cells of the thyroid gland, but it does not bind to cells on another gland because they don't have the right receptors for that hormone. Receptors are always being synthesized and broken down to accommodate any changes that might occur. There are various types of hormones. Hormones overall are categorized into 4 structural groups, with members of each group having many properties in common. The 4 structural groups include peptides and proteins, amino acid derivatives, steroids, and fatty acid derivatives. The next slide just gives you a visual of each category, the peptide, steroid, and amino acid derivative. It talks about the synthesis, the storage, the solubility, the receptors, the effects, and some examples of each. Please review this slide for testing purposes. So let's talk about peptide and protein hormones. Peptide and protein hormones are water-soluble. They comprise the largest number of hormones, perhaps in the thousands in the body. Some examples of these hormones include the antidiuretic hormone, oxytocin, and protein hormones such as human growth hormones and insulin. Amine hormones. There are two groups of hormones derived from the amino acid tyrosine: thyroid hormones and catecholamines. Our catecholamines really are the epi and norepi, which is produced in the adrenal medulla. Steroid hormones. All steroid hormones are derived from cholesterol, and they differ only in the ring structure inside in regards to the chains attached to it. May include glucocorticoids, cortisol, may include mineral corticoids like aldosterone, androgens such as testosterone, estrogen, and progesterones. Fatty acid derivatives. The principal groups of hormones of this class are prostaglandins, prostacyclins, leukotrienes. Prostaglandins are probably the most diverse group of regulators. They participate in the regulation of the immune system in regards to inflammation, pain, and fever, the reproductive system, the digestive system, the respiratory system, the circulatory system, and the urinary system. So these hormones are really, as you can see, the most diverse, affecting almost every body system that we have in some way. The next slide is just a list of the hormones and the glands that produce them. So please review this slide for testing purposes. The major human endocrine glands and some of their hormones is also listed on this slide. This slide would have also assisted you in filling out the handout today that we worked on at the very beginning of class. I encourage you to take the time to pause this video and watch this YouTube video that I've posted within the link. Moving on to the pancreas. The pancreas is situated behind the stomach in the retroperitoneal space. Exocrine and endocrine cells are found here. Exocrine cells are for digestive enzymes, and endocrine are more so for the hormones. Amylase, lipase, and other enzymes that aid in digestion. 3 types of endocrine cells within the isolate of Langerhans produce hormones that regulate serum glucose levels. They're listed here, 1, 2, and 3. The pancreas produces insulin. Insulin is an anabolic hormone released by the beta cells. It's stimulated by the presence of glucose and directly lowers blood glucose levels. It's an extremely important hormone in the human body. It helps to store carbohydrates, protein, and fat, helps transport potassium into the cells from the extracellular space, decreases fat metabolism and mobilization, stimulates protein synthesis, and the major disorder that is affected by insulin production is diabetes. Diabetes will be discussed in 2 weeks in class. These are some of the terms used for insulin and glucose imbalances. Please take time to review them. Effects of insulin on carbohydrate anabolism. Glucose is admitted to skeletal, cardiac, and adipose cells for the use as energy. Excess glucose is stored for later use as glycogen in hepatic cells and muscle cells. Central nervous system, or SNS, freely permeable to glucose. Insulin is not needed for transport of glucose across the blood-brain barrier. The effect of insulin on fat anabolism. Fat is stored in connective tissue, reduction in fat mobilization, and fat catabolism. Effect of insulin on protein sparing. Protein spared as an energy source. Protein is available for protein synthesis, amino acid transport into the cells, and the formation of blood proteins. This next slide is just a box that was in your textbook, agents that release or inhibit insulin. So it talks about the various hormones. Insulin release major stimulate elevated blood glucose levels, and insulin inhibition major inhibitor low blood glucose levels. So which hormones can affect elevated or low blood glucose levels, and alternatively what drugs affect it. So finally in the pancreas, we have glucagon and insulin and glucagon ratios. Glucagon is synthesized by alpha cells, and it has the opposite effect of insulin. It counter-regulates insulin and raises blood sugar levels. It forms glucose from non-carbohydrate sources and includes glycogenolysis and gluconeogenesis. The pituitary and hypothalamus. The pituitary gland is controlled by the hypothalamus. Think of the hypothalamus as the master gland. The anterior pituitary is the only place where hormones are produced. And they include ACTH, TSH, prolactin, FH, or follicle hormone, or LH, luteinizing hormone. The posterior pituitary will secrete hormones that are made in the hypothalamus, and this would include things such as ADH and oxytocin. The thyroid gland. The thyroid gland weighs 15 to 30 grams. It's wrapped around the 2nd to 4th tracheal rings, and it's bow tie in shape. We will talk about thyroid disorders in the coming week, but I figured we would intro to it this week. Our thyroid hormones include our T3 mainly, our T4. So please take time to review the thyroid hormones listed in this slide. The adrenal gland. It's small. They're bilateral organs located on the superior pole of the kidney. They're 3 to 4 centimeters and they weigh about 5 grams in adults. Hormones of the adrenal cortex: the glucocorticoid hormone, cortisol; mineralocorticoid hormone, aldosterone. Hormones of the adrenal medulla include epinephrine and norepinephrine. And these are really important for increasing our heart rate and blood pressure, and norepinephrine directs blood to the muscles and to the brain. The hypothalamic pituitary adrenal axis links the adrenal gland to the hypothalamus and the pituitary. So that's pretty much it for the endocrine system, those main topics that I wanted to briefly discuss before we moved into the actual disorders affecting the endocrine system next week. At which point we will go into a little bit more detail about those topics that I just went over. So a short discussion of metabolic disorders. I encourage you to pause this video and watch this YouTube video on metabolic disorders, which talks about what it really means, the definition and explanation of it. Really, a metabolic disorder is an abnormal chemical reaction in the body that alters the normal metabolic process. Usually, this is related to a genetic anomaly, so a defective gene that causes some sort of enzyme deficiency within the body. PKU is one we often test for in infancy. It's often done around 24 hours of age and includes a blood test on the infant that tests for phenylketonuria. While it was most often referred to as the PKU test, it's actually also called the newborn screening test because it no longer tests for only PKU, it actually looks for a wide range of genetic anomalies. But when we're talking about metabolic disorders specifically, I thought about bringing up PKU because it's one we test for in infancy. So can diabetes be considered a metabolic disorder? As we briefly talked about today in class, 100% it can. It's definitely considered a metabolic disorder, and we will go into more depth, pretty much a whole discussion about it in 2 weeks from now. So we did review these questions in class, but in case you did not write them down, I figured I'd just quickly go over them. So question 1, the answer was B. Hypoparathyroidism can cause low serum calcium levels. Numbness and tingling in the extremities and around the mouth area are the hallmark signs of low calcium. Normal calcium level, is between 9 and 11. Question 2, the answer is A. Diaphoresis and a high fever can lead to free water loss through the skin, resulting in hypernatremia. Loop diuretics, which is in part B, are more likely to result in hypovolemic hyponatremia. Diarrhea and vomiting can cause both sodium and water losses. And clients with syndrome of inappropriate antidiuretic hormone, or SIADH, have hyponatremia because they have an increased water reabsorption in the renal tubules. Question 3, potassium of 2, the answer is A, hypokalemia. Question 4, the answer is D, a normal serum sodium level is 135 to 145. A serum sodium level of 150 indicates hypernatremia. On the basis of this finding, the nurse would instruct the client to avoid foods high in sodium, such as processed foods, which have a high sodium content. Peas, nuts, cauliflower have a high phosphorus content. Question number 5, the answer is A. A normal serum calcium level is about 8.6 to 10 milligrams per deciliter. A serum calcium level lower than 8.6 indicates low calcium. Signs of hypocalcemia include paresthesias followed by numbness, hyperactive deep tendon reflexes. Additional signs of hypocalcemia include increased neuromuscular excitability, muscle cramps, twitching, tetany, seizures, etc. Question number 6, a serum potassium level greater than 5 indicates hyperkalemia. ECG changes associated with hyperkalemia include flat P waves, prolonged PR intervals, widened QRS complexes, and tall peaked T waves. And question number 7, the answer is A. Hyponatremia is evidenced by a serum sodium level of less than 135. It can occur in clients taking diuretics, the client taking corticosteroids, and the client with hyperaldosteronism or Cushing's syndrome are actually at risk of hypernatremia. So thank you for taking time to listen to this online audio recorded lecture. Next week again is an online lecture. I will go through it slowly and give you many opportunities to review some questions as well. It will be on metabolic disorders, specifically pancreatitis, thyroid issues, and adrenal dysfunction. Thank you very much and have a good week.